This is HM. He is 44 years old. For 6 months, he took omeprazole for heartburn. The heartburn was not heartburn. He found this out on the operating room table. This is what happened to his coronary arteries. HM was a smoker. 1 pack a day for 20 years. 20 pack years. He worked as an electrician. He told the anesthesia team he could climb 4 flights of stairs without stopping. That cleared 4 metabolic equivalents, or MET, the threshold for acceptable functional capacity before non-cardiac surgery. It is also one of the least reliable assessments in pre-op medicine. The 2018 MET study in the Lancet showed self-reported MET capacity does not predict 30-day death or MI, myocardial infarction. His blood pressure was 142/88, slightly elevated. He was not on any antihypertensive. His BMI was 31, a class 1 obesity. His father had a heart attack at 58. HM mentioned this, but did not consider it relevant. He had occasional chest tightness. He told his primary care physician it was heartburn. He was given omeprazole. The omeprazole was a guess. Nobody ordered an EKG. Nobody ordered a stress test. The chart said heartburn. The chart was wrong. By the revised cardiac risk index, his perioperative cardiac risk was low, less than 1% to be exact. His preoperative EKG, ordered per institutional protocol for patients over 40 with cardiac risk factors, showed normal sinus rhythm with a rate of 78. No acute changes. HM was induced at 8:55 a.m. Midazolam, fentanyl, propofol, rocuronium, standard. On laryngoscopy, his blood pressure spiked to 168/96. His heart rate climbed to 102. The resident gave a small dose of fentanyl and turned the sevoflurane up. The vitals settled. He noted the spike in the chart and moved on. The surgeon insufflated the abdomen with carbon dioxide to 15 millimeters of mercury of intra-abdominal pressure. The patient was placed in reverse Trendelenburg with the right side up. Standard positioning for laparoscopic cholecystectomy. The pulse ox sang at 99%. The case began. At 9:12 a.m., the anesthesia resident noticed something on the monitor. The V5 lead showed 1.5 millimeters of horizontal ST depression. V5 is the precordial lead that monitors the lateral wall of the left ventricle. It is the single most sensitive lead for detecting ischemia in the OR. Roughly 75% of intraoperative ischemic events show changes in V5. 3 minutes later, the depression deepened to 2.5 millimeters. The waveform sagged a little deeper with each beat. The BP cuff cycled, 96/58. Heart rate 94. End tidal CO2 38. The resident called the attendant. ST changes on the table are not always a heart attack. The team had to think through the causes. Lead placement could be wrong. It was not. The leads were rechecked. Electrolyte abnormalities can mimic ischemia. Point of care potassium came back at 4.1. Normal. Coronary vasospasms. Possible, but uncommon. Demand ischemia. This is where the heart muscles need more oxygen than the coronary arteries can deliver, but the arteries themselves are not acutely blocked. Tachycardia, that is fast heart rate. Hypotension, that is a low blood pressure. Anemia, that is a low hemoglobin. Hypoxia, that is a low oxygen content in the tissues. Any of these can cause it. This is a type 2 myocardial infarction. Plaque rupture. An atherosclerotic plaque in a coronary artery cracks open. A clot forms on top of it. The artery is acutely occluded or near occluded. This is a type 1 myocardial infarction. In the operating room, you often cannot tell the difference in real time. The attendant entered the room. Phenylephrine, which is a blood pressure medication used intraoperatively, was given to raise the blood pressure. Esmolol was given to slow the heart rate. The goal was to reduce myocardial oxygen demand and improve coronary perfusion pressure. The surgeon was notified. The case was 30% complete. The surgeon looked at the field, 3 clipped arteries, an undissected cystic duct, a bleeding bed if he stopped now. The anesthesia attendant looked at the monitor. ST depressions 2.5 millimeters, heart rate 94, blood pressure 92/56 on phenylephrine. The decision, finish or abort. There is no algorithm for this. Aborting is not always safer. Aborting meant closing the patient with active bleeding sites and an unfinished dissection. That carried its own risks. Finishing meant 10 more minutes of insufflation, 10 more minutes of catecholamine stress, 10 more minutes of ischemia. They chose to finish, but finish fast. The surgeon worked. The gallbladder was removed at 9:31 a.m. The abdomen was desufflated. The patient was extubated awake at 9:48 a.m. ST changes had improved, but not resolved. A 12-lead EKG in the PACU showed 1 millimeter of ST depression in leads V4, V5, V6, and lead 1. A high-sensitivity troponin was sent. The team waited. It came back at 412 nanograms per liter. Normal is less than 14. HM was transferred to the cardiac care unit. Cardiology was consulted. Serial troponins peaked at 8,400 nanograms per liter. He was diagnosed with a non-ST elevation myocardial infarction, also known as an NSTEMI. A transthoracic echocardiogram showed a new anterolateral wall motion abnormality. Ejection fraction, 45%. His baseline was presumed normal. Standard NSTEMI care is dual antiplatelets, anticoagulation, and a cath within 72 hours. HM was 18 hours postoperative. Each of those drugs could make him bleed profusely. They went to the catheterization lab the next morning. They deferred the P2Y12 load until after stent placement. They used bivalirudin instead of heparin. The catheterization showed 95% stenosis of the proximal left anterior descending artery, also known as the LAD, the artery that supplies the front wall of the left ventricle. This was a type 1 myocardial infarction. A plaque had ruptured during the surgical stress response. The catecholamines, the tachycardia of intubation, the hypertension of incision, the inflammatory state of surgery, all of it had stressed the vulnerable plaque until it cracked. The spike on laryngoscopy was the first hit. A drug-eluting stent was placed. Flow was restored. HM was discharged on hospital day 6. He was started on aspirin, ticagrelor, a high-intensity statin, a beta blocker, and an ACE inhibitor. He was told to stop smoking. He was referred to cardiac rehabilitation. His ejection fraction recovered to 55% at his 3 months follow-up. HM's case is not rare. 1 to 3% of patients over age 45 undergoing non-cardiac surgery suffer a perioperative MI. Most are silent. Most are NSTEMIs. Most are missed. 3 things HM told us. None of them registered. The heartburn was angina. 6 months of warning, treated with a proton pump inhibitor, omeprazole. The father dying at age 58. A genetic flare, HM mentioned and was dismissed. The cigarettes. 20-pack years at age 44 is not a young patient with no risk factors. That's a patient with significant atherosclerosis until proven otherwise. The signal was there. The receiver was not. HM was lucky. He had a vigilant resident watching the V5 lead. He had a surgeon willing to move fast. He had a cardiologist willing to navigate the antiplatelet dilemma. Most of all, he had a wake-up call. He stopped smoking. He started exercising. This is HM's story. If you enjoyed this, please like, subscribe, share, and comment. I'll see you guys on the next case.